So we had several questions submitted. So I think we're going to get right into those questions today. And it's interesting that the questions fell around three main areas. Questions specifically related to people living with dementia and behaviors, research, and of course the world that we're living in right now with COVID-19 and the pandemic. So, Dr. Scharre, I'm just going to start right off, get some of those COVID questions out of the way. Does Alzheimer's disease or any other dementia increase the risk of a person to get COVID-19?
Thank you, Pam. And is everyone able, are you able to hear me all right?
Yes.
Okay. Happy to be with you all and appreciate the Alzheimer's Association's efforts to help to educate as best I can, answer your questions regarding cognitive issues and dementia. So the question was regarding COVID and what particular about it?
The question was if a person is living with Alzheimer's or other dementia, are they any more at an increased risk to get coronavirus?
So they're not at an increased risk for getting it. You get it, of course, by being within 6 feet of someone and them having droplets land on you or touching a surface and picking it up that way from people that have deposited it on different surfaces. So as far as we know, they're exactly the same risk as everyone else from getting it. It's just what happens to them after they get it. Do they have a severe course or not severe course? And so with older individuals, and Alzheimer's are usually older, they have more comorbidities, that is other medical conditions. And so they're going to be at higher risk for having more severe cases and perhaps dying from this condition than maybe a youngster would have. But they do not seem to be at any higher risk of picking it up. But if they do pick it up, they might be at higher risk for the consequences of the disease.
Okay. Is there anything in particular that you could recommend that we could do to keep our people living with dementia healthy during this time?
It is a challenge, and a lot of you on the line, I'm sure, are facing this challenge right now, and it's difficult. So the patient with dementia, depending on how severe the case is, don't understand it. Will forget that you told them about some virus. They won't understand not touching things. They won't understand keeping social distancing 6 feet away. They will be into things that maybe haven't been disinfected, etc. So those living in assisted livings, those living in nursing homes are particularly at risk. Living at home, you have to watch out to who comes in and disinfect right away if someone comes in the house, because you don't want them to be passing it along to the one with cognitive issues. So it is extremely difficult to make sure everyone is safe. But the best way is to keep people away from them as best you can. They need help. So obviously people need to be involved and they need to be close. And so it's important. Obviously we have to care for them correctly, but the least amount of people that are involved with them physically is better. You know, FaceTime and Skype and other devices we have for video communication, try to use those. But it's a tough time for caregivers and patients with this condition.
Yes, it sure is. It sure is. So we're going to kind of move then into the research questions, Dr. Scharre. With all the challenges that the pandemic is presenting, do you still think that there are opportunities to get involved in research?
Well, clearly we need to move forward with all our research projects because Alzheimer's is going to be around long after this pandemic has died away, and we need to continue to find best treatments and best options for diagnosis, et cetera. So yes, our treatment protocols right now, those that are already ongoing, that is those that are the patient is already enrolled and they're getting treatments such as infusions or injections are still ongoing. We do them very carefully. We make sure that they get their safety assessment. So if they need some sort of safety for MRI to make sure the drug or the medication is not impacting their brain, we do that. We do blood safety evaluations. So those people are still coming in under very safe conditions to our clinic, to our research center, and we are taking care of them. What has been put on hold right now is, as you might expect, new enrollments. So these are people that are not in the middle of a trial and need to have safety assessments, and it's very important to carry the trial forward. And so those have been put on hold right now. We're hoping to open that up eventually here. Exactly when is uncertain, but I would think certainly in the next month or two that we will be back to better shape. I don't make any predictions. We don't want another peak of this infection. Going through one, I think, is enough for all of us. And I personally would rather wait another little bit so that we're really sure that we can open up a little bit more than having to suffer through another peak. Those of us that are in there in the hospitals and on clinics and on the front line, definitely appreciate not having to see another peak come through. So I'm not super eager to suddenly open up all clinical trials for new enrollments, but my guess would be maybe a couple months, or maybe it's going to be a month. We'll just have to sort of see how things go. But we have lots of trials in the waiting for new enrollments. I can go along a little bit about what we're doing right now in research. May cover some other questions as well, but
yeah.
So very exciting, different studies that we are currently doing for dementia and Alzheimer's. We have studies going on right now in Lewy body dementia, Alzheimer's disease, mild cognitive impairment, even some prevention trials. Those right now are closed to enrollment for early prevention if you don't have symptoms. But we're looking at a whole variety now of new agents that we really haven't been tried before. So these are anti-tau agents. Tau is a protein that builds up in Alzheimer's disease. We've been focusing a lot on amyloid, which is another toxic protein that we see in Alzheimer's disease. We're doing now treatments that are trying to get rid of this tau protein, and this is the one that's probably most correlated with dementia. So the more tau you have, the more dementia you are, or more cognitive issues you have. Amyloid is less related to the degree of dementia because it's less involved in killing the nerve cells, whereas tau is directly involved in killing the nerve cells, causing more memory loss and dementia. So we're working on new tau drugs. We have synaptic modifiers to help with the communication between the nerve cells. It tries to help repair nerve cells. It improves the communication between the two nerve cells so that they're healthier. We're going to eventually have a combination of all these things, right? We may have an anti-amyloid, get rid of that, get rid of tau, help the cells be happier. Like diabetes, high blood pressure, we have maybe 3 or 4 drugs that someone may be on for one disease, right? They all work in different ways. The same is going to be true for Alzheimer's, and we're developing now some wonderful new ways to look at that. I'm involved in a variety of other studies now that could perhaps investigate repair mechanisms, reducing inflammation in the brain that might increase damage to nerve cells. So we're looking at immunology, we're looking at repair functions, we're looking at ways to try to get rid of amyloid and tau. So it's a very exciting time now in dementia research. We also have studies with behaviors, so we know that's very important to reduce abnormal behaviors, and we have ongoing studies to help reduce agitation, finding better treatments that don't have as many side effects, don't make someone too zonky or sleepy. That can help with some of these behaviors. So new drugs are being tested for that. We're looking at things such as robotics for caregivers and for patients. So we starting a study where you have a pet rock. No, I mean a pet robot. Some of you are old enough to remember the pet rocks, I think. Anyway, but pet robot. I don't know if any of this is going to work. We're trying. We're trying the best we can. So will that comfort, provide comfort and attention to a dementia individual? Right now with the COVID, everyone's distancing. Maybe the robots are a good thing to have. Maybe the patient won't recognize them as anything and just ignore them. So anyway, we're trying very hard to find ways for caregivers, patients, helping with apathy, helping with stimulation with these robots, maybe engage them more. A caregiver can't be engaged in a patient 24/7, even though that's helpful for their brain, because they got to do, laundry and shopping and finances and 20 zillion things. And the patient, of course, may be sitting there looking at four walls or a TV set or something like that for a large part of the day. That's okay right now. That's what we have. But if we have other ways to engage their mind, that might be helpful for their brain as well. So we're looking at sort of therapeutics through engagement for things of that nature. So there's a whole gamut of things that we're working on, very exciting, and we can't wait for COVID to get over, but we will wait a little bit longer.
That's great, Dr. Scharre. Thank you so much. I could listen to you talk about all the great research you're doing all day long, because I know that there are caregivers and families out there that are desperate at different times. So thank you so much for all that you're doing there. It's very, very exciting. We have a lot of questions about behaviors and so forth, so I'm just going to kind of start in with some of those if that works for you. Could you address the benefits, drawbacks of medications for behaviors associated with dementia?
So great question. There's always questions regarding behaviors and some myths and some misconceptions about these medications. In particular, there's a group of medications called antipsychotics. These are medications that are designed to help people that have false beliefs that they're recurring. Maybe they think that this is not their house, they got to leave, or maybe they think that's not their husband, or maybe they think that someone is taking their things, or maybe they think that someone's being poisoned to them, or why do I have to do this, or you're just doing this for some other ulterior motive, and there's a suspiciousness. So they have suspicious and fearfulness, and I don't trust you, and you may tell them reality, but you can say whatever you want, is not going to change their mind, right? And it may disrupt caregiving abilities. They may not trust you. They may not take your medications that you've given to them. They may not want to take a bath. They may not want to do lots of things because they're fearful or they're suspicious. And so there are medications out there that are fabulous to help with these types of symptoms. Unfortunately, all of them right now through the FDA have these black box warnings on them for these antipsychotics saying danger, danger, you should not give in a dementia patient because you might kill them or cause strokes or some other horrible type of condition. And so these are been placed on as a class effect. So every antipsychotic has this, even though they don't have proof that all these medications have caused any of these symptoms. They just throw it on the whole class, whether it's true or not true. And some of the medications in the antipsychotic class, particularly things like Haldol and some of the older antipsychotics, can have a lot of side effects and can be very zonky, making of people and sleepiness and making them not really function too well. That's not good. We definitely don't want that. Others have been listed with a gait imbalance and falls. That's also a horrible thing. You don't want to break a leg with these things, break a hip. Others have been associated with increased movement, shuffling, or the tremors, or they've been associated with other things. There are very few of these medications. We know which ones they are that cause these troubles more than others. We avoid those. And there's other medications which have very, very few side effects and have been fabulously helpful in patients with these conditions. And so there are great medications out there that can be used very safely, have almost no side effects. You can titrate the dose, so if you get some side effect, you can always come back down. And they help with these symptoms so that someone can not have suspiciousness, not be psychotic, not be a little bit more cooperative with their care, and not be so angst. It's a horrible thing for the patient. I can't imagine being angst like that, thinking someone's going to poison you or take your things or stealing or did something nasty to you or whatever it might be. It's a horrible feeling. Who would want to live that way? You would want to treat your individual. And these medications work in the brain. The Alzheimer's is a brain disease. It affects the brain. So, yeah, it makes sense. You need to give medications that work on the brain. So antipsychotics in the right doses, the right types are very effective. Do not be afraid of them. Use them. And you should use them initially so that when the symptoms first start, don't wait till they're throwing things at you or twisting your arm or, getting angry or injuring yourself or them or so you can't even get a caregiver in to help you care with them, if you're at home. Don't wait that long. These things should start early when the symptoms first start, and then you can give them very low dose. And it takes care of the issues, and so they're happy, and caregivers are happier. Other medications we have for behaviors, there's ones that work great for depression and anxiety. These are called antidepressants. They're much better than anti-anxiety medications, which are horrible for dementia patients. These are like benzodiazepines, Ativan, lorazepam, those types of PAM drugs. There's medications that are great for restlessness. They're moving, they can't sit still, they're up and down, they're getting into everything, they're packing, they're just, where did you put that now? You hid it under this other drawer, and they're moving things, and it takes the caregiver then another several hours just to try to make sure they don't wander out or they don't, moving all the important papers somewhere else, et cetera. So there are medications to help with this internal restlessness, work very well. We have meds that work well with sleep. Sleep is fabulous. You need sleep. Sleep is very important for Alzheimer's. So sleep seems to help be a good time where you can get rid of some of the toxins in the brain. So if you don't get good sleep, your Alzheimer's is probably worse. So they call glymphatics in the brain. That's sort of like the lymphatic system in the system. They call it glymphatics in the brain, and they tend to get rid of toxins, and that seems to occur mostly when we sleep. And so if the patient with Alzheimer's is up and down, up and down, up and down, they're not getting rid of those toxins very well. And you're miserable if you have to be with them because they can just sleep the next day, half the day, and take a nap, but you can't. You got work, you got other things to do, and you can't be up all night trying to care for them. And so it's horrible for caregivers. It's horrible for caregivers' mental and physical and cognitive abilities. It's not good for the patient's cognitive abilities. So we have lots of great treatments for sleep. Very important to get sleep. Make sure they don't have sleep apnea. Treat that. And then things like initiating sleep with melatonin or sustaining sleep like with trazodone. Some very safe medications that can be used in many patients that help with sleep. So we can treat sleep and restlessness and psychosis and depression and anxiety and intrusiveness. Impulsivity is a treatable type condition. We may not get rid of every single behavior, but we can at least lower it down so it's tolerable, and maybe it's only happening, once a week as opposed to every day. Well, I'll take that, it's better than every day. So talk to your doctor. Talk to them about these behaviors. If they say, there's a big black box warning, we really don't want to give it, either find another doctor or just say, okay, well, just try a little bit, see if it helps, So try to get them because that's going to help their brain and help you take care of them, which is also going to help them.
Dr. Scharre, you were talking a little bit about sleep, and I want to circle back to that in a minute. But we just had a couple of quick questions come in the chat in regards to medications. So before we move off the medication topic, let me, a couple of questions here. How do you feel about Xanax for restlessness and sleep for someone with dementia?
So Xanax is not typically very one that we really like. It's a benzodiazepam. Um, it causes confusion. It's addictive. Sometimes it will build up tolerance, so then it won't work as well. So you have to give a little higher dose. Um, it's just something you should probably try to avoid in dementia patients because it causes oftentimes more confusion and restlessness than not. Some people can do really well with it. If you've had a long history, for example, of anxiety and you've been on these medications for 30 years, then it's probably okay to continue it because you have a different condition as well as Alzheimer's. You have an anxiety disorder, and if it's been really helpful to you, I think it's okay to continue the dose that you're on if you've had this for many years. But if you're taking these medications for the dementia behaviors, only after you got dementia are you having these anxiety issues. There's much better treatments for sleep and for anxiety than things like Xanax that work really well. Sometimes you need a combination of an antidepressant for the anxiety and maybe trazodone, which is also an antidepressant for sleep. Those probably are safer and less side effects for the patient.
Awesome. Great. Thank you. And then the drugs that you were talking about earlier, the antipsychotics and so forth, another question came in, are these good only for people with Alzheimer's or also for those having symptoms from things like a brain bleed from a trauma, like from a fall?
It's a good question. Antipsychotics seem to work on every type of psychotic condition. So whether you have schizophrenia or bipolar disorder with psychosis or severe depression with psychosis or brain trauma from bleeds or infections or anything, if you're psychotic, they are super drugs to use and definitely worthwhile to use. The side effects are usually minimal if you keep the dose down, and you can usually control the side effects, and they're non-addictive medications. You will never become addicted to an antipsychotic. And so there's lots of benefits to these medications.
Awesome. Great. Thank you so much. Let's shift over to the sleep questions then. You had referenced sleep a little bit ago. One of the questions that came in said, how much should I let my husband sleep? He goes to bed at 8 p.m. and may sleep until noon. Sometimes he's up at night. So what's your feelings on sleep?
I like it personally.
Me too.
In fact, I'm going to take a nap now. No, okay. That was a quick nap. Yeah, so as I mentioned, sleep is so important for so many reasons. And so I won't repeat what I mentioned there. But to initiate sleep, so this individual, it sounds like they're sleeping a lot, right?
Yes.
And so so we see that sometimes more often in things like Lewy body disease. It's very, very common for Parkinsonian type stiffness and falls and stumblies and mass face and dementia. That's sort of typical for Lewy body disease. They sleep constantly, and sometimes it's really not sleep. I think sometimes it's just closing their eyes, and they're just sort of zoning out a little bit, and so I don't know if they're actually truly sleeping. We're right now doing a very I think important study looking at sleep studies in Lewy body patients. Very interesting data we're finding, and imaging studies, and so in those individuals that sleep a lot, one of the things that we suggest, especially in the morning, so 8 p.m., maybe that's okay time to go to sleep, right? You can get things done at night. Usually people don't have too much problem with 8 p.m. It's maybe sleeping till noon that's more of the issue, right? So some things that help with activating the brain and increasing focus. In the morning, you give your donepezil, or if you're on the Exelon or the rivastigmine patch or the galantamine. These are medications that are used for Alzheimer's and Lewy body dementias, vascular, stroke-related dementias at times. These medications are good with activation of the brain. They're alerting, focusing. Many doctors start these medications in every evening. So that's really not the ideal time to start them. Switch them to the morning. They work all day, so it's okay. If you're on donepezil in the evening, that's called Aricept as well, is the other name. That's the brand name for it. Or galantamine, it's usually twice a day. But if you're on the once a day, switch all of those once a day meds to the morning. It helps with alertness and focus. Maybe they will get up more before noon. Other things that we may try to help in the morning time for alertness is psychostimulants. So sometimes we'll give like a Ritalin. This is like methylphenidate, or these are things like you give for children with attention deficit disorder. So these are stimulant medications, and low doses can sometimes help real well, sometimes with frontotemporal dementias, Lewy body dementias. If you want to try to get them up and sort of moving a little bit, being engaged. If they're not engaged, they're not using their brain, so that's not helpful for their brain. Use it or lose it. So you want your brain to be engaged and focused. And morning time is good to do that because everyone else is up in the morning. Middle of the night, we don't like you to be engaged because everyone's trying to sleep. So we want you to sleep at night, and we want you to be up in the mornings when we have energy too. We can maybe engage you in the morning time and then do our tests in the afternoon. I don't know. So some patients, we can try stimulants. If they have sleep apnea, sometimes that will cause you to sleep all night and half the morning because you're not getting restful sleep. You're not getting to the deep layers of sleep. So sleep apnea will keep arousing you, maybe not till you wake up at night, but maybe just below when you're waking up. But you never get to the deep levels of sleep. You're just always sitting here at the surface. And so treat your sleep apnea. Make sure that that's treated, and that might help so that you're not sleeping till noon.
Great, Dr. Scharre. Thank you so much. We appreciate that insight on sleep. Let's switch over to eating now. We had some questions about eating. We had one person write in that their wife is always wanting to eat. She's in the early stages and gets upset with me if I try different approaches. Is this something I should share with my doctor?
So excessive eating, usually for later stage dementia, we worry about not eating enough. So people lose weight, and we're trying to encourage them to eat. And we're giving nutritional supplements, and we're feeding them snacks and giving a lot of ice cream and different things like that. But if you have excessive eating habits, that's usually a impulsivity or a compulsion or obsession. You're thinking of eating all the time. We see this a lot in frontotemporal dementia patients. They have this sort of obsession with eating and want to eat. In fact, one of the best suggestions there is to, lock the fridge. They'll go in and raid the refrigerator and start stuffing their mouth. Maybe they eat too much too. That could be dangerous for choking. And it's sort of impulsive behavior. So they see that potato chip. They like potato chips. They're going to have one. Then they'll have another, and they'll have the whole bag. And they won't know when to quit. They see a snack. They'll like that, a candy bar or whatever. They'll start eating everything. And sometimes they'll get into food fetishes. So they'll just like one particular thing, and they'll have that constantly, and then they'll switch to a different particular food. We see that as well. So number one, environmental controls can be useful. So out of sight, out of mind. So you don't have the snacks in the snack place. You have them hidden in a place only you know about, or up in the high closet, or you can, put a lock on the refrigerator. I had a patient that thought I was crazy saying this initially, and now she's a believer. And after about 6 months of whatever technique she used, she put a lock on. It's worked like a charm. And so she believes in that method right now. So there's also medications that we can try to control impulsivity. That's a brain condition. It's affecting all behaviors come from the brain. It's due to abnormalities and levels in your chemicals and your neurotransmitters. And so they get off when you have Alzheimer's or Lewy body or frontotemporal. And so giving a medication may help stabilize these neurotransmitters in the brain. And so there are medications that work well for impulsivity or eating too much, sometimes for obsessive compulsive disorders. So there's a variety of medications. Some tricyclic antidepressants work really well for that. Sometimes some of the mood stabilizers drugs work really well for that. So talk to your doctor about, which one might fit best with them. But I usually use a combination of those types of things, helping the impulsivity for wanting food, etc., and then also environmental controls.
Great. What treatment options do you recommend for a family member who has a family history of dementia and is starting to show signs of mild cognitive impairment?
So the first thing that needs to be done is they need to get in to see a physician if they haven't already, and it's important to tell the physician that there's a family history and there's a change. You can be a very, very, very smart person, and they can do their simple tests with you, and you may do perfect scores on these simple tests. But the family knows, no, you used to be a fabulous artist, and now you're here. Or you used to be a unbelievable organizer, and now you're having trouble. Or you used to be math genius, and you're here. Or you can find your way anywhere in the world, and now you're calling up to say, how do I, get to, place X, Y, or Z. So, but you're still maybe average to other people in those domains. So you need to be able to listen to family members and informants very carefully to say, there's been a change from their normal talents, and that's critical, especially if there's a family history. You're primed and you know that this may be coming. The earlier you start treatments, the better you do. Even the current treatments that we have right now, the earlier you start, they seem to have a slower course. And so you don't want to delay a year, 2 years, 3 years until it's like obvious. Get them in for evaluation. Even all the treatments we have for mild cognitive impairment, the new studies we're doing, they work better. These disease-modifying treatments that we're trying to get out that aren't approved yet, they all work better the earlier you start them. So if you're interested in a clinical trial, perfect time to get into clinical trials or to be evaluated is just when you're beginning to see there's a change in my husband or my wife or my mother or father. If they're resistant to go into a doctor or to investigate any of that, sometimes that occurs, it's okay for you to call the doctor on your own. And you can be anonymous, you can muffle your voice up, they're talking like this, and turn off the video, so that they can't come back and say, you must have called the doctor, or you could just, of course, be truthful and just say, my wife has been having problems. It's not horrible, but I've been noticing it. Can you please check her for some memory loss next time she comes in, because she didn't want me to come in, and she doesn't believe that I have it. And so please check her out for reversible causes of thinking problems. And if it turns out to be something like Alzheimer's, then these treatments work much better the earlier you start. So with a family history, if they're starting to have mild cognitive impairment, get them into a physician and or directly to one of our memory center or someplace like that can really start the process rolling early.
Dr. Scharre, is there any particular kind of supplements or medical foods that you would recommend to help someone in this early part?
So it's a good question. The brain, for whatever may cause problems with it, including degenerative conditions, including Alzheimer's, to function well, the brain needs good oxygen. So you need to make sure you're getting enough oxygen, lung disorders or sleep apnea or these other things. So number one. Number two, it needs good nutrients and needs food. And that includes, of course, glucose from regular food. It needs all the vitamins. You need all the vitamins in your brain to make it function well. You need to have well-balanced diet. The Mediterranean diet, low in saturated fats, sort of more vegetable oils, and a lot of legumes, a lot of fruits, a lot of vegetables. Less of the carbohydrate types of things. Starches are typically thought to be more healthy for your brain. So it's good to have a nice balanced diet. I think if you go too far off on any one particular diet, whether you think it's the most healthy diet in the world, if you're not getting, if it's sort of excluding vitamins and other types of things, you need to include those. So well-balanced meals is very important. In terms of supplements, if you're getting these well-balanced meals, you're probably okay. The ones that have been studied the best or the most in Alzheimer's in particular, only one has really shown to have some benefit, and that's vitamin E. So that's an antioxidant vitamin. It's designed to help heal the nerve cells. Just in our normal living, we get radiation from the cosmos, and they hit our whole body, but they also hit the brain. They poke holes. They get these little electrons that fly off. Electrons can damage the nerve cells. So antioxidants get rid of these extra electrons from just random damage to our body, and heal up the nerve cells or heal up the kidney cell or whatever it might be that's damaged. And so antioxidants generally help cells heal themselves, and a complete cell is probably working better than one that's full of holes or not, working on healing. So antioxidants are thought to be good for lots of different things. The recommended daily allowance for vitamin E is 30 international units once a day. In Alzheimer's, they did a study many years ago looking at high doses of vitamin E. And so it turned out that higher doses seem to help reduce outcomes, so seem to slow down the course a little bit. Maybe it would work. We have no proof. If you're at risk for Alzheimer's, say your mom has Alzheimer's or your dad has Alzheimer's, and you're getting to that age when they started having their symptoms, or maybe a few years earlier, maybe you're middle age or something like that, and you say, can I do anything right now to prevent me from getting mild cognitive impairment or Alzheimer's? So maybe trying an antioxidant then. So vitamin E, we usually don't suggest more than 200 units a day. There's been some studies, and that's about 7 times the recommended daily allowance. There's been some studies that have used 2,000 units, and some studies that have shown over 400 that might have some adverse events. So if you stay below 400 a day, you're probably seems like you're completely safe in terms of any side effects from it. If you take 200 in this pill, plus you're going to get some in your vitamin pill, another 30, plus you're going to get some in your food, another, you'll still be under the 400 limit. And so 200 units a day is very, very safe. Probably anyone can take that. We think it has some benefits. We did with the Alzheimer groups. Whether it helps beforehand or not is unknown, but that's something you could consider. The other big thing I'll mention is, and so to go back to just medicinals, over-the-counter stuff, nothing else really that has been tried has really shown benefit. So fish oil, for example, didn't show benefit in Alzheimer patients. None of these agents have really been tried for mild cognitive impairment or for people that don't even have symptoms, so we don't really know. There's studies with these over-the-counter memory aids, that they're advertised quite heavily. They're only been tested really in normal aging process. Normal aging is not dementia. Normal aging is not Alzheimer's disease. Normal aging is not trauma to your head or strokes to your brain, or so they haven't really had any studies, nor do they have to, because it's a over-the-counter medication. Doesn't fall into the FDA guidelines or rules to have to be stringently tested. So we really have no idea whether they would be helpful at all for someone with mild cognitive impairment or dementia or Alzheimer's disease. Most of them are pretty benign stuff. They probably don't cause a lot of side effects. If you have money and you want to take them, you can. I say, if it helps you, well, you can continue it. If you don't see much help, then maybe you want to save some money and buy something else with the money, So the studies are really not there for dementia or MCI for those agents. The last thing I'll mention in terms of things that you can do for prevention is lipids. So cholesterol or lipids that can build up in the body, and we know them specifically as things that can clog up our blood vessels, right? So if you have high lipids or cholesterol, you're at increased risk for heart attacks, you're at increased risk for strokes. And so we get treated with these medications called statin medications, and those are helpful to reduce the lipids. But there's a big connection between Alzheimer's disease and cholesterol. There's a genetic risk factor called apolipoprotein E. This is a gene that you have that can be, if it's a certain ApoE4, then you're at increased risk for Alzheimer's. And ApoE is a cholesterol transport gene. So what's a cholesterol transport gene have to do with Alzheimer's? It seems to be a big risk factor for Alzheimer's. And we've done studies with transgenic mice. These are mice engineered to look like an Alzheimer patient. They're not Alzheimer's patients, of course, and it's not the same disease, but they're made to sort of be a test model for us for Alzheimer's. And the more of the statins that you gave these mice, the less amyloid they had in their brain. They had also less cholesterol, but they also had less amyloid in the brain. So, and all humans that took statins for their cholesterol in midlife had a 70% reduction in dementia rate than those that didn't take statins for their cholesterol. So these are all retrospective, not cause and effect. They're just data out there. But it suggests from all these things that I think cholesterol has something to do with Alzheimer's, perhaps. There's some link somewhere there. We're still trying to work it out. If you take a statin and already have Alzheimer's, it doesn't seem to help. We've done those studies. So it could be that you need to take it before you get Alzheimer's. So in your middle age or something, if you have high cholesterol and your mom or dad has Alzheimer's, you're at increased risk genetically because you have a family history of it. Don't just maybe try diet or something. Take a statin. Take a medication for your borderline cholesterol or high cholesterol. That seems to actually help reduce maybe amyloid possibly, no proof yet, but possibly reduce this toxic amyloid. If you're doomed to get Alzheimer's, it may slow down and give you a few extra years before it really develops into your brain. And so, and of the statin medications from these studies, only the ones that got in the brain are the ones that work. So Pravachol and others that don't pass the blood-brain barrier, can't get into the brain, didn't seem to have this dementia risk reduction. And only those statin medications that got in the brain had this. So again, there's a link that maybe these statins are good for a reduction of amyloid. And the one that gets into the brain the best is simvastatin. So if you have to take a statin medication, you have a parent that has Alzheimer's or had it, and you have cholesterol problems or lipid issues, talk to your doctor about possibly switching to simvastatin or to get to a statin that gets into the brain.
Great. Thank you, Dr. Scharre. That's very, very excellent information and very helpful. I'm going to switch topics a little bit for you and address a couple of things that are in the chat. One question came in. My spouse's mother had dementia. Whoops, the chat moved, so I'm going to circle back here. Sorry about that. My spouse's mother had dementia, and now I notice that my spouse's mind isn't as sharp as it has been, and she has some difficulties in remembering things that we've just discussed. Should I engage my spouse with these concerns I have?
Well, I'm always a person that's truth is better than anything. You just explain that I've known you for a long time. There's changes. You may not notice it as much. And you have this family history, and that the known medications we have work better the earlier you start. I mean, if you have, sometimes I suggest, it's like a cancer type of thing. Alzheimer's is not cancer, right? But you can have a little bit of a lump. Say you have a lung nodule or something like that, and they look at it and go, well, it could be cancer. We don't know, but I have no symptoms. Well, lung cancer runs in the family. We could just sit and watch it and see if it grows. And if it grows, then you have MCI, you have lung symptoms. And if it gets worse and metastasizes, then you have dementia, sort of equivalent to dementia. And it's your options are much limited if you have dementia already. You don't have as many options, right? If you have metastatic lung cancer, you have some options, but they're not as good as if you're catching it at stage 1 and you can maybe pluck that thing out and be cancer-free, right? So the medications we have right now, even though they're not the greatest, work better the earlier you start. So you have better brain for a longer period of time. It's well worth getting in the very first symptoms. And what you describe is someone that get them into a physician, convince them to give this, that the medications will work, help prevention. We do stuff for preventing strokes. We do stuff for preventing high blood pressure and cholesterol to prevent strokes and heart attacks. this is just something else we can do to help prevent our brain from deteriorating.
Great. Another question came in. Are there any studies or programs at OSU looking at healthcare disparities and how to reach communities that may be at a higher risk of Alzheimer's and dementia, but perhaps don't have the means or resources for typical healthcare processes? What would you recommend for individuals at a disadvantage?
Yeah, excellent question. Education, I think, is the key. So we are working. Right now we have a project with Dr. Wright, particularly looking at African Americans, and this is regards to increased risk with high blood pressure in particular. Diabetes is a big problem with that group, and there's links between diabetes and hypertension and strokes and dementia. It's unknown whether they actually get Alzheimer's disease more than others, but there's some hints out there that they might as well. But all of these comorbidities, these high blood pressure, hypertension, particularly prominent in the African American community, perhaps related somewhat to diet and other things, genetics. And so we're making a special effort to studies particularly focused on the African American community and these healthcare disparities. So that's one thing we're doing. We're using treatments, education programs, getting them in to explain what they can do with their diet, better diet, reduce hypertension. Then we're watching to see if the cognition is improving. Another thing that we're doing is for people that can't get into doctors as well is to increase our access by telehealth. So right now we're learning a lot more about telehealth, and I call it telecog for cognition testing and for seeing patients. But before COVID came about, we were starting a process at Ohio State where we were increasing our tele-access to communities outside of Columbus. You know, they can't get to the big mega center, or who wants to drive to Columbus anyway and deal with all the traffic, and it seems kind of scary, and I don't want to go there, and it's my memory is not that bad anyway, just leave me alone. And so patients don't want to talk about their failing memory because it's embarrassing to them, and they don't think they have much of a problem anyway, and you're just trying to bug them, and maybe you're trying to put them into a facility. Who knows what you're doing, So they're accusing you of doing things you're not really doing, and they don't want to come to Columbus. So we're trying to increase our access. So we're trying to start a program. Hasn't been started yet. We were just engaging some areas outside of Columbus in an access program so that they can communicate through telehealth a lot with our nurse practitioners because we have a big problem with getting enough patients in. So we're trying to hire and train nurse practitioners to be able to handle some of the excess load. And they would be very well-trained individuals because they're trained by us, of course. And, could be able to, for the typical Alzheimer patients or typical dementia patients, should be able to get help they need. And maybe it will help with getting other people in to see their local physicians as well. So we're trying to experiment that out with some of our research.
I agree. That's a great question, and we know that there are populations that are more susceptible to the disease. So thank you so much for answering that question, Dr. Scharre. A couple of questions have come in the chat, and then we had some questions submitted ahead of time. What are some ways that we can help reassure our loved ones with Alzheimer's or dementia that are currently in a care center that we're unable to visit them right now?
Yeah, I think that's an extremely hard question. I don't have good answers. People use the bang on the window outside the building technique, and they have the the Skype and the FaceTime and all those types of techniques, and iPads. Most facilities have iPads, so you have a bigger picture of someone, they could call up. And so those are types of things. It's not the same as in person. Everyone knows that, I think. And you can't really hug or kiss or whatever. And so it's tough on everyone. And I don't think there is any good answers. And in fact, if people want to chat in what they've found that's been useful, we could share a few of those on the line here, but
Absolutely. Yeah.
I'd be interested as many to share with others. We're just stuck with this situation. On the other hand, it is so rampant. It can be so rampant in nursing homes. They're so vulnerable. They touch things, they pick up things. It's just so much safer just to stay away from nursing homes. I would agree with the ban on visitors, the ban on as many outside people as possible. I do video chats now with my patients in nursing homes. I encourage all our primary care docs that go to nursing homes to only physically see the patient if maybe they have a rash or they having trouble breathing. You want to listen to their lungs. You have to do some physical activity with them. Okay, then yes, see them. But if it's something that someone can show you a picture of their swollen foot or this or that, you may not have to actually put hands on them. Stay away during this time. Stay away. Don't spread it. Don't let it get into the facility. Wash, clean, disinfect, all these types of things. But I think we have to really do that. Otherwise, we hear all there's horror stories out there, and it's has nothing to do with the status or the how good a facility is. It can come in any different ways, and so it's not a reflection, in my opinion, on how good or bad the facility is. It matters what they do afterwards once they find a case to separate. And we're stuck right now. It's a horrible situation. We need more testing. I'm fighting constantly with Ohio Department of Health and other people. We need more testing in nursing homes, and we just don't have enough right now. It's starting to open up. Hopefully by the next couple of weeks we'll get more and more, but it's still a big issue.
Yeah, it sure is. And Dr. Scharre, thank you for advocating for that. I think that's really, really important. Just a couple last questions here. We had some questions dealing with quick changes in mood and behavior. What are some suggestions you have for dealing with those quick changes that we might see in our loved ones?
So if quick changes mean like anger comes and goes, they're very nice, all of a sudden they just turn on you, or angst, yes. Anger, irritability, resistiveness to care type of things. You can't predict those because unless you just never talk to them or never ask them for anything, it's usually triggered by, I want you to do something. You're bossing them type of thing, and they don't want to do it, and so that's usually the quick anger. If you leave them alone, usually they're fine with that. So, but obviously you have to get them to do things. You got to get them to go to the bathroom and eat and do this and that and bathe. So normally the best treatment for those, because it's because you can't control it. This is from the brain, is really medication. So medications work really well for these quick angers. Sometimes one of our favorite drugs for that is Depakote or Divalproex. But it really helps with this impulsive blow up of anger. And it may not get rid of it completely, but it really makes a caregiving life a lot easier. So you need medication. Behaviors come from the brain. The brain is damaged. We have medications that help control some of these chemicals. And you can't do all this with just environmental control. You can try, but you need a combination of environment plus pharmacotherapy.
Great. Thank you, Dr. Scharre. Any closing comments that you'd like to leave us all with today? It's about 5 of 12, so we'll be wrapping this up. But anything else that you'd like to share with all of us today?
No, appreciate just the chance to answer questions and educate. Our goal is to really, the key is diagnose early. The symptoms that you have early on, your loved one or spouse better than anyone, and you will notice changes faster than anyone else. So get them in for diagnosis as soon as possible. And then number 2, I guess, as we discussed, use it or lose it. Physical activity is great for the brain. Mental activity is great for the brain. Socialization, you can't do it now, is great for the brain. Stay away from nursing homes. Treat behaviors. They're just an angst. They feel horrible, and we shouldn't deprive individuals of behavior medications just because we're fearful of the drug. The drugs are very safe and used in appropriate doses. Help your loved one with their horrible behaviors, because I'm sure they're not enjoying them any more than you are. And so. And then really, there's thousands of things to talk about. We're doing research. We're trying to find better ways and treatments for these conditions, and we appreciate all of our research, subjects and informants and family members that are willing to go through research, even though they may be on a placebo. That's how we learn, and that's how we get better treatments out. So I appreciate everyone out there on the call or who's participated in trials. Thank you very much for that, and that all helps all of us find drugs and get control of this condition faster.
Awesome. Great. Well, Dr. Scharre, we can't thank you enough for being with us today. Thank you for taking this hour out of a very, very busy schedule. And we just appreciate everything that you do for patients and families. And thank you so much. And thank you to everyone who participated today. We're glad that you were here. So thanks, everyone. I'm going to stop the recording. And Dr. Scharre, thanks again. We can't thank you enough.
Okay, thank you. Stay safe.